Welcome to the ICU podcast. I'm your host, Callie, a registered dietitian living with interstitial cystitis. Each week, I'll be diving into hot topics in the IC world, giving others a platform to share their story, and I may even reveal some of my favorite nutrition tips. Thanks for spending time with me today. Now, let's get into the episode. Okay, everyone, welcome back to the ICU podcast. Today, I have Dr. Robert Echenberg with me. He is actually my current IC doctor, so I really am excited to have you on. Thanks for coming on.
Well, thank you very much, Kelly, for having me.
Of course. Can you introduce yourself and just tell everybody, what you currently are doing in your professional career?
Well, it's a very good question because it has changed considerably over the decades. I started out as a regular OBGYN doctor here in Bethlehem, Pennsylvania, way back in the ancient times of the early 1970s, and did a lot of work. I was always kind of trying to think outside the box and did a lot of work over the years with birthing processes and various things when medical ethics and things like that I got interested in, because a lot of that stuff we were not taught in medical school. And things were changing in the 1970s. There was a lot more demand for Lamaze birth and that sort of thing. So I became kind of known as the doctor who wanted to help the increasing number of women who wanted to follow those courses of their birthing experience. And then over the years, developed some interest in attachment and loss and various other grief kind of things. Again, things that were not taught very much to us before becoming, kind of a doctor for women. Gynecologists often are the one doctor that people go to if you're female and go to on a regular basis. So I needed to learn other issues, including sexuality and other kinds of things. So I went to a lot of conferences and joined a lot of groups, national groups and so forth. And then later I brought the first nurse midwives into the Lehigh Valley here for the first time. And there was a demand for that, but the hospitals weren't too keen on it back in the 1970s and early 80s. Things are a lot, for those who are kind of used to today's ways of approaching OB and GYN, things were a lot more difficult for women, I believe, in the 70s and 80s, because we were still coming out of an age where everybody was separated at birth from their partner, and all kinds of things were going on that were not like the things that people are used to today with birthing rooms and all the, people coming in with cameras and families, and even children can come in for birthing experiences, and none of that was going on back in those early days. So long story short about the pain program is that I got back from, my wife and I were in New Mexico for a few years. Actually, I was working in a hospital near the Mexican border in Las Cruces, New Mexico. And for the first time, actually working with a group of doctors and nurse midwives for a very indigent population of Mexican farm workers that were coming across the border. And we had a really nice program going, and it was very well supported by the hospital. And I was very much enjoying it, but it was a little too far from the East Coast where our grandchildren are and so forth. So we ultimately came back, and then at the beginning of the 2000s is when I was asked in our department to come up with some type of an approach for especially young women who were exhibiting a lot of lower abdominal and pelvic pain and were not being diagnosed appropriately, or very, very difficult to figure out why they kept having lower abdominal pain. And in the category of the lower abdominal pain people, we often would be doing laparoscopies, taking a look with surgical procedures into the pelvic cavity, into the abdominal cavity. and either finding nothing or finding very little evidence that would cause the amount of pain that people were exhibiting. So a lot of those folks were either labeled as, emotionally difficult patients, or we couldn't figure out why they were in so much pain. I came across interstitial cystitis right around that time because I went to a conference, and one of the primary physicians in the country who was doing a lot of research on it at the time, a urologist from the West Coast. And at the time that I went, it was in the late 90s. I didn't think it really was up my alley, so to speak. As a gynecologist, I thought all of that was urologic, and we already there were trained urogynecologists coming along around that time. And for regular GYN, I just didn't think I had to worry about that. Once I started investigating about why a lot of the young women were having not just abdominal pain, but pain and problems that were recognized, unfortunately, often not correctly, as urinary tract infections or vaginal infections and all sorts of inflammatory things that reacted in the pelvic and genital area, such that it was difficult to treat a lot of those folks because they either would keep coming back with what people were calling a yeast infection or a UTI, and being treated with ultimately lots of antibiotics and lots of antifungal agents, and then sometimes also associated with lower abdominal pain and deeper pelvic pain, and having surgeries and just going around in circles and being sent to different specialists and so forth. I'm sure the audience that's listening to are the ones that have interest in IC and probably have gone through that route of seeing tons of different specialists and either not getting the answers or having lots of procedures and then being told, well, we really don't know what's going on, or looking things up on Dr. Google and getting even more scared.
Yes, absolutely.
So
and
that's
support
common.
groups. Yes.
Yeah. You hear that a lot, I guess. Yeah.
Yes. And, everybody I know is going to be so interested in what you have to say and, what your treatment style looks like. So can you kind of take us through that?
Well, what I discovered early on, and what I really needed to learn a lot about, like I said earlier about birthing things and various women's issues that were not taught to us in residency, was chronic pain itself. I discovered very quickly that even though I had been a gynecologist for about 30 years when I started this program 20 years ago, so that kind of ages me right there. So the thing that I realized is that there was a difference between acute pain and chronic pain, and persistent pain that lasts over 3 to 6 months is considered chronic pain, meaning persistent pain. Also, when we give a diagnosis of complex chronic pelvic pain, that doesn't mean just that it's more complicated or difficult to figure out, but complex meaning there's a number of different components that cause the region of the pelvis to be painful. And one of the things I want to say right off the bat is that I learned that the pelvic region is basically everything between the belly button and the mid-thigh. And if you think about the pelvis as that entire region, that encompasses, as you can see, more than just your gynecologic parts. And it would include the upper buttock area. It would include part of the low back and where the low back becomes the pelvis. It's hard to delineate because they're obviously attached to each other. And it includes the hips, and includes the tailbone, the sacrum. It includes all the sit bone area. So we have a lot of patients at this point over the years developed. Most of the people that we see are quite complex, and people who haven't been able to get help in many of the other specialties that they have seen. So we see a lot of people who have had a number of surgeries, a number of invasive diagnostic tests, and are still frustrated because they don't have a definitive diagnosis, and not just with interstitial cystitis, but with all of the other diagnoses that they may look up and discover online and get even more terrified about some of these diseases and disorders like vulvodynia and vestibulitis and pelvic neuropathies like pudendal neuralgia and pelvic floor dysfunction. And I'm sure many of the people listening here kind of know those terms at this point, especially if they've been around a bit to pelvic floor physical therapists, and oftentimes they'll learn more from the physical therapist than they might learn from some of the doctors that they've seen. So it's a complex area because there's so much going on. I call it the busiest part of the body. 24/7 you have bladder function, 24/7 you have bowel function, and 24/7 until your menopause you have reproductive function going on. And not only that, structurally, you can't not use your pelvic region. You and I are both sitting at the present time. I think you're sitting, but a lot of the patients that I see, as you probably know, can't sit comfortably because the weight of their body is sitting right on the sit bones, which are called the ischial tuberosities. And like the term cycle syndrome or bicycle syndrome, the sitting on a bicycle seat becomes very difficult for a lot of people. Not just long distance bike riders, which it's not uncommon for them when they're riding hundreds of miles to get numbness and tingling and burning and stabbing and various types of ugly types of descriptions sitting on those tiny little hard seats for hundreds of miles. And they have to stop riding for periods of time. So most of them get better if they're off the bike for a while, but then there's about 15 or 20% of them who just can't ride anymore at all. And that 15 or 20% are pretty much the people in the category of the population that we see with pelvic pain, because there's about 20% of the population that has a predisposition to chronic pain disorders, such as migraine or fibromyalgia, low back pain, TMJ, all of the other fibromyalgia, other kinds of chronic pain disorders that overlap with the pelvic pain disorders. And the pelvic pain disorders that I kind of listed a little earlier, the model of our program pretty much is the same model that I needed to learn in those early years, around 2002 to 2010 or so. I was going to a ton of pain conferences and realizing that the neuroscience was exploding. And I didn't actually realize that because none of that neuroscience information of how pain is actually processed and how it's different with acute pain and chronic pain was not even being taught, not just to the medical students that I was seeing, but it wasn't in the category of topics that came into the kind of programs that an OBGYN doctor or a urologist or a GI doctor would go to their conferences and in their journals. So I specifically started reading and going to conferences involved with chronic pain management. And what we discovered, and what we still say a lot, is that the doctors who work in the pelvic area, which are the gynecologists and the urologists and the urogynecologists and the GI doctors, pretty much don't know about chronic pain as far as the neuroscience, up-to-date issues of it. And the doctors who are pain management doctors avoid the pelvic area. So when you are a man or woman with pain in the pelvic region or the genital region, you kind of are in limbo because none of the doctors are comfortable and they're not comfortable because they just haven't had specific training in that area. So it becomes, like a pinball machine. You get bounced around from one specialist to another, and ultimately find that nobody gives you. One of the biggest things that people say when they first see us is that I've seen all these people and I still am confused about what diagnosis I have.
Right.
I don't even have a label to it. And some people, and I'm sure some of the people who are listening to would kind of relate to this. Some people say, I wish I had cancer, because
I've
then I
heard
would
that
have,
so many times from people.
I would then have a specific diagnosis and a plan of action. And so many people are ready to kind of jump off the cliff because they're hurting so much and nobody is listening and always believing them, that they're desperate. And it almost sounds good to get chemotherapy and to have your cancer treated, because at least you're acknowledged and you're validated and you have a diagnosis. If the treatment doesn't work, you might be very bad for you, but at least you are going down a recognized path of medical care, and that's on you, and not the common outcome of pelvic pain. So the model of our program, basically, I think, is what you asked me originally here. I go off on tangents.
Oh, it's okay.
Is that we basically are a pain management program for the pelvic region, which is unusual. It's one of the only practices, private practices like this in the country. And we do get inquiries from all over the country, all over the continent, and even a lot of inquiries online from our website from Europe and Hawaii, and we have people from Alaska who have come down here, and from Europe and so forth. So I have had patients actually now from about 15 countries that have not been able to find help. And a small handful of those people can't even get here, but we commonly do video calls with them, not just with COVID time, but even before COVID. I was doing some video calls because obviously we couldn't see somebody quickly if they're from across the ocean or in California. So video calls became a really handy way to be able to be up close and personal with people. We also have an 18-page questionnaire that we send out to every new patient. And you mentioned that you were a patient. So
yes, I remember filling that out. It took like a couple hours. And I think it can be overwhelming when you look at it, but when you realize what you are taking into account, that's really powerful. Like it develops a level of trust before we even meet you, I think.
I've heard that quite a bit. We sometimes apologize to people that it's such a long questionnaire. And what I have found myself as a patient, obviously I'm old enough to have gone to other doctors myself and have a cardiologist that I've seen and other types of specialists and so forth, is that you fill out a lot of those papers before you go to see those people and nobody's ever looked at them.
Right.
You fill out the forms and then you get asked by 4 or 5 different people the same questions over and over that you already wrote down. So what we're doing is actually reading those questionnaires, and I underline them before I even talk to the person, and make some notes and have a little outline of what I think is going on, even before we have the initial conversation. And I think that's what you're talking about, is that when I get online with somebody, or in the past when I'm seeing somebody in person for the first time, it's reassuring to them that I actually know something about them before the encounter. And the questionnaire was put together very strategically to ask a lot of the different organ systems and a lot of the different, excuse me, activities that the people have had, including many of the sports that they have done, even if they're maybe 50 or 60 years old. What sports did they do when they were in college or in high school? And what, how were they utilizing or overutilizing their pelvic core muscles and doing stretching? And I commonly say that it seems to me that almost all little girls want to be little gymnasts, when they're 4 or 5 years old, and want to put their legs straight up in the air and do the split. And many of them go to these classes, either dance classes or gymnastics classes, and they're very healthy and wonderful for socialization and all. But it's not necessarily healthy when people, I hear, in some cases, actually push these little kids down so they can do the split better, kind of forcing the issue. And I have pictures that I show new patients of athletes, really good athletes, ballet dancers and gymnasts and various other sports that utilize the pelvic core muscles and all of the stretching of the nerves in that area. And that's the other thing I say, is that I was a gynecologist for 30 years and delivered lots and lots of babies, about 3,000 of them or more, and did lots of surgeries in the pelvic region. And yet I forgot all the nerves, muscles, and ligaments in the pelvis. And I won the anatomy prize in medical school way before you were born. And then I forgot all those other parts that I actually now kind of just come out of my mouth very easily. As you remember, we talked about different muscles in the pelvis and different nerves in the pelvis, and we go to the neuromuscular part of the pelvis in many cases. And basically the model is, okay, there's a chronic persistent pain in the pelvic region. Some people notice that it's their bladder and come in because of bladder issues, or have been told they have IC in the past, but were treated only very briefly, or just gave up on being treated and just kind of do the best they can with their diet and so forth. And some people have kind of stabilized, but a lot of other people come in with no bladder symptoms whatsoever. But we discover, when we ask the right questions, that those people, even if they come in because they can't sit comfortably, or because they can't have intercourse comfortably, or they can't do their sports anymore, or they're challenged because they have to get standing desks at their workplace, all of those kinds of things because of pelvic pain, and have seen all the different specialists, nonetheless, the bladder, when we talk about it, still comes up about 70 or 80% of the time. So even those people who come in and say, I've been diagnosed with pudendal neuralgia, I have irritable bowel, and I can't sit comfortably, we ask the right questions. Are you one of those people over the years that when you go to the movies, or you go to the theater or movies, or a theater or a restaurant, do you have to pee before you leave the house? Do you make sure you pee when you get there? Do you make sure you know where all the bathrooms are in the mall? You probably, everybody that's listening right now is probably nodding their head. Yes, that was me. But we're talking to a bunch of people that are, kind of specifically interested in interstitial cystitis, painful bladder syndrome. But oftentimes, and about 60 or 70% of the total number of people that I see, the bladder is somewhat involved, even if it's not their primary complaint. And you might be very interested in this in your audience, that the male patients that I see, a significant disproportionate number of men that I see end up having interstitial cystitis and bladder symptoms and urethral sensitivity and tenderness. And much to their surprise, because many of them have already gone to urologists and have gone to some other specialists and have found and never have been examined, sometimes at all, they just get a history and are told they have prostatitis. and get treated with antibiotics over and over and over, just like young women are treated for yeast infections over and over, or UTIs over and over. That happens with men with their prostate. And then we discover that the urethra is running through the prostate, and that's actually what's causing their prostate to be palpated and found to be tender. So it's ubiquitous is a good word to say. In pelvic pain in general, people that have pain between the belly button and the mid-thigh, a very significant portion of them, one of the triggers of that pain is the bladder and urethra, and also what's called the vestibule of the vaginal opening, and the anatomy of that. And it's a shame enough that most young women in their teens, in high school and middle school and so forth, don't really get the appropriate information about their own anatomy. But many people that I see have PhDs and beyond, and are highly professional, well-educated folks, and don't know the word vestibule, often don't know what vulvodynia actually means. And it becomes like a whole new revelation to them to hear those terms.
Yeah, you're so right. And I didn't know any of those terms. And from my history, I went and had the vestibulectomy, vulvectomy, and I didn't even know what I was getting done. I just didn't understand. So you're right. We're not taught about that.
You need it. It's not that mysterious and mind-blowing to know that you can show pictures to somebody and then compare those pictures of the anatomy, the deeper anatomy, the external anatomy, and then show on the physical exam the corresponding parts and show with a mirror.
Right. Oh my gosh. You guys were the first doctor and medical facility that actually had me looking at my pelvic region. And I actually had never even known where my urethra was before until you guys were. I remember the first time I was getting assessed by you, and either you or Anna, Anna's the nurse practitioner, right?
Nurse practitioner, yeah.
So she was like, do you want a mirror to look? And I was like, oh, no, I'm good. And because, it's a little uncomfortable, but then you were trying to teach me about it. And I realized, I'm going to get the most out of this if I'm actually looking. So it was so helpful. And, you were telling me, put this cream on your, vestibule or something like that. And, it helped so much to just look at it, see that there was irritation, and it really just did help so much.
Yeah. And the detailed differences between the outside skin, the hair-bearing skin on the outside of the genital area, is a totally different type of tissue than the lining of the vagina. And then the vestibule that we're talking about, for those people that are listening that aren't clear about what that is, that's a part of the anatomy that's in between the outside skin and the lining of the vagina. It's the skin covering of the inner lips. So it runs from the tip of the clitoris all the way back to the back part of the opening. And that tissue is entirely different type of tissue than the others. And this is a very, very important little point, especially with people that are listening that have IC, is that the embryological development of the lining of the bladder and lining of the urethra, which are affected by IC, embryologically, those tissues also develop from the same tissue, the vestibular tissue. So the vestibule of the opening is this embryologically the same, comes from the same tissue that the lining of the urethra and bladder do. And that's a kind of a revelation for a lot of people, because it kind of explains why many of the young women that we see, and even the older women, look back and say, I've never been able to put a tampon in comfortably, even when I was 13 or 14 years old. And I just thought it was me. I just thought that I just have a smaller opening, and it's hard to ask around who's having trouble and that sort of thing. And many mothers don't know what to do about that. And they're also developing sometimes frequency and urgency at the same time, which, if you're 14, 15, 16 years old, and also playing 2 or 3 different sports and strengthening your core and getting all that part of your body really worked out and sometimes overused, and also have inflammation in the bladder and the vestibule. And that vestibular sensitivity, that irritation or inflammation of the vestibule, is called vestibulitis, meaning inflammation of the vestibule without being infection, which is a big, big difference. So for vestibulitis, you don't treat it with antibiotics or antifungals, even though so many people, when they are young and they go to the doctor and the doctor sees a little bit of discharge and redness around the opening, oh, you must have a yeast infection, and people get treated over and over. And the other thing is the relationship between frequency and urgency. Those people who are dealing with bladder symptoms also have the vestibular sensitivity in many cases and don't know that they're combined, that they're connected. And once you do know they're connected, sometimes you realize that when your bladder's flaring up, that's the time when the opening is more sensitive, more burning, more irritated, more feeling dry. All types of descriptions are given. And that vestibulitis or vestibulodynia, meaning pain in the vestibule, just like vulvodynia dynia means pain in the vulvar region, but vestibulodynia is part of vulvodynia. That vestibule is part of the external genital tissue, not part of the vagina. So that's another thing that's totally misunderstood by most people, is where does the outside, the end and the vagina begin? And most people don't realize that tissue of the vestibule is in between. And it's where the urethra comes out. And there's just so many people who even their brain confuses the sensitivity that they're getting from their urethra. And sometimes the urethra, which is up in the front part of the vestibule, is causing some irritation or inflammation or discomfort. And the brain is misinterpreting that, because where the real sensitivity is way in the back in the vestibule. So that's another thing that we teach people. And it's really, really important to have a person take a look so they can see when I use that little Q-tip. You remember that little Q-tip test?
Yep.
And probably a lot more people nowadays are getting tested with that Q-tip, because 15 years ago, hardly anybody was doing that. But at least more and more doctors are at least checking people that way. But just the touch of a Q-tip in that area can be, some people say it feels like a knife. Some people says it feels like sandpaper. And they can't believe that they're so sensitive. And then they take a look and see that very light touch and say, oh my God, I didn't realize that. I thought it was just me always being dry with any type of attempt at penetration, whether it's at the doctor's office getting a pap smear, or trying to put a tampon in, or just being touched there, or trying to have intercourse. So all of those things, probably a lot of your patients, a lot of the people listening and a lot of our patients don't even know those things are connected.
Right. And, before I had my vestibulectomy, I would have like 10 out of 10 pain during that Q-tip test. And I thought that surgery completely took everything away. But then when I saw you and you were poking around with your Q-tip, there was still spots that were pain. And you were like, that is still the vestibule. And I was just amazed by that, because my brain was confused about it.
Well, it's really impossible to take the entire vestibule out. So that's why they say partial vestibulectomy.
Mm-hmm.
It's really, for those people who don't understand what you're talking about there, it's the back part of the vestibule. And I don't do surgery anymore, so I haven't even done that surgery, but it's a simple surgery to do. It's sometimes really, it really is a game changer for some people. If the topical medications, if the dietary things are not helping, the nutritional things for the IC, or for their IBS for that matter, because I see people that have irritable bowel who also have vestibulitis, because the same nerves that go from, the bladder and the reproductive organs and the lower bowel go into the sacral area, S2, 3, and 4, and that's area in the tailbone produces the pudendal nerve, which comes back down through the buttock area and out right where your sit bones are, and then flares into the whole under the skin of the entire vulvar area, from the pubic bone all the way back to the tailbone. So everything in the vulvar area, perineal area, perirectal area, and inner thighs is innervated by branches of the pudendal nerve on both sides. There's a left pudendal nerve and a right pudendal nerve. And if you remember the way we examined you, we also examine not just your bottom, but your lower abdomen and groin area.
Mm-hmm.
And we turned you over on your stomach, and we checked some very specific landmark areas of the bony tissue in your lower pelvic area in your hip. And we found the piriformis muscle, and we found the obturator muscle, and we found different trigger points. I don't remember exactly with you, and it doesn't matter, but this is what we typically do with all of our patients, is front, back, and bottom.
Mm-hmm.
And actually meticulously examining the entire pelvic region.
Mm-hmm.
And so many people say that they have never been examined in all those areas before. And interestingly enough, and many of the female listeners that you have right now, we put the men, we go through the same thing. We examine the front and the back and do trigger points and sometimes nerve blocks and different kinds of treatments, and then put them up in stirrups. And it's always interesting to watch, especially if they have their wife with them or their partner, their girlfriend, whatever it might be, sitting in the room nowadays with a mask on, of course, smiling from ear to ear because their male partner is up in stirrups.
Yeah, that must be a sight to see.
Yeah. Well, we do it discreetly, and we have them hold their genitals up a little bit with a towel and so forth, because from the base of the scrotal area down, if that's what we're looking at, it looks exactly the same in the male and the female, the perineum and the perirectal area, and where the pudendal nerves come out, and where the obturator muscles and the pelvic floor, everything is exactly the same. So I was a little bit, as a gynecologist, kind of anxious about when I first started seeing male patients, and I was reluctant initially, and I just was not trained to do male stuff,
Mm-hmm.
which is why most of the male patients go to the urologist. But now we're seeing that so many of those people with pelvic pain and can't sit, so many of them actually have never really been given a diagnosis of IC, and yet we find that their urethra in the perineal area is very, very tender, sometimes along with the pudendal nerves, and sometimes they need also to be treated the same way as a woman would be, with the appropriate diet and some of the aloe vera products and the anti-inflammatory things that you can get through Desert Harvest Company,
Mm-hmm.
and even using Relivium from Desert Harvest, which has got some 4% lidocaine in it. It's a lotion that is really, really helpful for
Mm-hmm.
both men and women for nerve sensitivity anywhere in the pelvic area, including the genital area, and even including the vestibule area. So slowly but surely and gently and incrementally, we try to lower the peripheral nerve sensitivity. At the same time, if somebody has widespread kind of pain issues, not just widespread in the pelvis, but a lot of people we see also have migraine and back pain and other types of chronic pain issues. They have a central issue, central sensitization. Mm-hmm. So some of those folks require and do well with low doses and incremental doses of things like Lyrica and gabapentin and Cymbalta. And some of your listeners may know those medications. Sometimes they may be saying, oh, I tried that and it was a horrible medication. Well, sometimes I've heard too many people being started at too high a dose of some of those things. But our program is really integrative. We try the best of all worlds. So we're talking about sending people to acupuncture. Almost everybody goes to a physical therapist, whether it's a pelvic floor physical therapist or a general myofascial massage therapist, because as you know, Callie, a lot of people, if you can't touch somebody with a Q-tip, you don't want a physical therapist right off the bat to be doing internal release, because it just would be too painful and uncomfortable for that person. But we know, and you may have heard me say, I bet you have trigger points throughout your entire body. Because if you're bracing your pelvic core muscles and your pelvic floor, that goes both directions. So almost always we see people that have in their neck, in their shoulders, in their upper back, in their torso, and even in their chest, in the in between muscles, in between their ribs, they're hurting because they're bracing like this all the time.
Right.
Even if they don't realize it, they're bracing. And so a general myofascial therapist is really, really very, very helpful. There's also mind-body relaxation exercises that we highly recommend. There's a wonderful website called curablehealth.com, which is run by some really good practitioners on the West Coast for people with chronic pain of all sorts. And they have a lot of neuroscience information meant for easy consumption and people for understanding pain itself. The more you understand how pain is being processed, how the signals that are coming from your pelvic and genital area, why they're coming from there, why the inflammation is there, and then the second, and just as important, how are those signals received in your midbrain? And I say midbrain because the midbrain is a portion of the brain that chemically remembers and lays down every single thing that we've ever experienced. That's a hard concept to understand. But it's not hard to understand. And you may have said this to you in the office, but you have anybody can think about the time you walk into a wonderful bakery that has wonderful smells. And it just overwhelms you because it feels so good. And it immediately takes you back to your 7th birthday party where your grandmother made this wonderful cake and it smelled exactly like this. And you're 35 years old. And it took you back 25 years, just in an instant, because it's all there. So not just the bad things are remembered, but all the good things as well. And it's all in there. It's just that we don't think about all those things all the time. But if you're watching a movie or hearing something or smelling something or tasting something, or somebody touches you in a certain spot, it can take you back to the most wonderful moment of your life. It can take you back to your wedding. It can take you back to the song that you loved most when you were in high school, whatever it might be. But also things can remind you of bad moments, of trauma, of trauma, I call good trauma and bad trauma. You have the trauma of the good trauma, which is what I was talking about before, doing all those sports, overusing your whole body when you're playing soccer for 7 or 8 or 10 years, or gymnastics, or field hockey, or dance,
Volleyball.
or volleyball for the taller girls. Yeah. And all of those things use the pelvic region, use the whole body basically in such a fashion. And so many people play through pain and don't even realize it. When you're the heat of the game and you're a good player, you don't want to come out, and your coach doesn't want to take you out. So, I've heard that so many young women are saying, the coach is saying, and the manager is saying, man up, get out there and play hard.
Rub some dirt in it.
And that, wins the game. And it's really good for your teammates because, you want to win. The goal is to win. And most of the time that's okay. Even if you're playing a little bit on a sprained ankle, it'll clear up. And 80% of the time, and 80% of the people, it just means you hurt a little bit for a short time. However, in the other 15 or 20% that have that genetic predisposition, it might 15 years later, associated with IC or IBS or endometriosis or some other injuries that have occurred along the way, whether they're obstetric injuries or surgical injuries, or when I say injuries, I don't mean things that have gone bad, but just the process of having a baby, the process of having surgery is traumatic to some of the tissues, obviously.
Mm-hmm.
So we have people that look back and say, all of my pain started when I had this accident. I was in this car accident, or I fell on my butt, or even some people will say it started when my mother passed away, because I was so, close with my family and all that. So that trauma, that emotional trauma and people look back and say, I was perfectly healthy until then. And all of this just kind of came upon me really quick, like an avalanche. And then we start looking at their total picture and their total life, and looking back at all the sports and maybe other injuries that they had that were accidental injuries, and possibly surgeries or things that they may have been born with. And we have a handful of people who had started to have surgery when they were babies because of some congenital abnormalities. And so their whole nervous system has been primed even from early childhood. And then there are people, of course, who have been abused in one way or another. But I call that the bad pain, the bad trauma. There's good trauma and bad trauma. The good trauma we kind of bring on ourselves and overuse things that shouldn't be that overused or stretched out. So many traumas along the way are very, very common. But remember the big ones. So the point I'm trying to make here is that it's not necessarily that surgery or that childbirth or that one accident that caused that person to end up with this particular pelvic pain, regional pain syndrome. It's a combination of them living close to the edge for a lot of years and then going over that edge when even something minor happens.